interesting discussion today. It's a pleasure to welcome Dr. Stefan Baral to give joint rounds today for CHES and for the Leong Center for Healthy Children. I'm going to give his bio and then explain a little bit about why about the kind of the background rationale for rounds today. So Dr. Baral is a physician and an epidemiologist who, I'm still trying to understand this, works clinically in Toronto, but has an academic affiliation and as a researcher and an associate professor in the Department of Epidemiology at Johns Hopkins School of Public Health. His background is in community medicine and family medicine, and his clinical work is in the care of people in homeless shelters in Toronto through the Inner City Health Associates. In his role at Johns Hopkins, he's the director of Key Populations Program, and has done a lot of work, particularly in HIV. And more recently, Steph has done a lot of work related to COVID and particularly issues related to inequities and disparities as they relate to COVID. And for those of you who were at a business meeting last week, Astrid and Ellie Adler presented some of our visioning for the Leong Center, which is going to be a research center focused on disparities. And I just wanted to quote something I read from Twitter from Stefan Baral that I think is very apt for the conversation today about the issues of inequities and disparities as they relate to COVID. So Steph, correct me if I'm misquoting you here, but this is what I think you wrote. You wrote that health disparities and social inequities are a little bit like gaining weight over the holiday season. It doesn't take very long to gain the weight, but it can take months to lose it again. Disparities being reinforced now are going to be felt for years to come, which I think is very apt for the topic that you're going to talk to us about today. So without further ado, thank you, Dr. Baral. We look forward to your talk and the conversation.
Yeah, thanks, Yale. So, I mean, I think, indeed, I am used to, I think as many of us are, giving talks. This is a new talk for me, so I think folks, as long as folks are patient with me, that'd be great. As Yale said, so normally in the pre-COVID era, I do family medicine up here, and I work clinically, or I should say I work full-time as a researcher at Johns Hopkins, and that's because I tried doing clinical work in Baltimore, and needless to say, it's different, and I enjoy it more here, and some family connections. So, you know, by way of training, I did all my training in Canada, medical school Queens, and residency in community medicine, now called public health and preventive medicine, at University of Toronto, and family medicine similarly at University of Toronto. And so I think I come at this actually from a very Canadian perspective, and have had the fortune now of working with a number of other Canadian investigators on these projects. I'll say I hold no financial disclosures. I am on, as noted, CHR funded COVID research projects, but actually there's no personal salary associated with those. And obviously I do clinical work, but no real disclosures. So in terms of some of the things I wanted to do today, I wanted to first to try to sort of make the link about how this infection, just like so many before, in fact, every infectious disease before it, is one where risk is not evenly distributed, and addressing the sort of underlying individual and network structural determinants is actually critical for a meaningful response. So I'll first start with that, and I'll show data from a few different places, and then I'll kind of come to finish that section with data from Ontario, because it's true here as it's true everywhere else where we've looked at this empirically. I'm going to then sort of bring us back. I think, you know, what's so interesting for me is that as I did my residency, the thing that we use as kind of our Bible was the SARS-1 report, or the Naylor report. And some of you may have seen this report, some of you may have not, but it was really a focus of like the renewal of public health. And it's what led to the development of what was originally the Ontario Agency for Health Protection and Promotion, and now Public Health Ontario. It led to FAC, the Public Health Agency of Canada. And so those were all formed in 2004 based on this report. And so I always go back to that report because I think it still is, it still holds a lot of useful insights for us. And so I'll talk about some examples of like how I think it's a little bit challenging for me to understand the sort of approaches that we've used now, just again, in very traditional public health principles, and maybe the disconnect between what I see really as unmet needs resulting in these inequities and the way that we've addressed them to date. And then it'd be great to have a conversation about that, because I think the most important thing in public health, and particularly the last 7 months, it's a lot of individuals. It's been a very individual kind of like, this is my message, as compared to the way we used to do it, which is really in a teams-based approach. So I'll just start with saying that, you know, as far as it goes, as far as infectious diseases go, the idea of like heterogeneity and transmission risks is a fundamental principle of infectious diseases. It is a fundamental principle of like core epidemic theory that I can think of very few infections, if any, where like risk is evenly distributed. And so thus, to me, as you know, I think Eyal talked about, like equity is probably my framing for everything in life, ideally. And so equity here means that, you know, one would want to like address the actual conditions that are either mechanistically or causally increasing risk in some folks, and try to do that in a way that actually avoids concentrating risks among others and among the most vulnerable. And it is the case that like really well-meaning interventions can concentrate epidemics that really make them harder to control. I'll ask just Marie if there's a way to like mute the sound when somebody joins, but if not, it's okay. But I would just say that I think that even really well-meaning interventions can really concentrate epidemics, and I think that's known in a lot of settings, and I think it's been particularly true during COVID. So I just want to start with sort of, you know, we hear a lot about like, there are folks every day that are publishing like the RT, which is basically like the effective reproductive rate or the reproductive rate at any one period of time. And it's normally presented as either a provincial average or a municipal average. And I'll say, I think looking at that, I think some of us who focus on infectious diseases, it pains us a little bit, I think. Because it presumes that it's like the risk is homogeneous in any one setting. And the way that we would traditionally do like RTs in meaningful ways would be to try to delineate by whatever it is that whatever data we have available to us. And so whether that is, you know, for HIV among particular communities like gay men, for example, people who use drugs, whether it is here for respiratory infections among particular communities where we know that individual and network risks are more concentrated. And so that when we think about the RT, we try to separate it out also into sort of two things. And as we'll talk about, sort of like, what is one's individual or network level acquisition risks based on who they are and the context in which they find themselves? And then what is their transmission risks? And I think in between those, we think about these sort of meaningful individual and network level interventions that can be used. And so I just, anytime, maybe like a little like core nugget is that whenever one is presented an RT, it's just to sort of question like, you know, this idea of like the tyranny of the mean, which very much applies to these determinants. Who are we erasing? And what needs are we erasing as we look at that particular value? Because I think when we look at it at a community or a municipal and particularly a provincial or even a country level, we just remove so much heterogeneity so as to almost make it like, it just doesn't feel very helpful. So when we think about, you know, sort of transmission of infectious diseases, traditionally we like to sort of think about it in terms of like at least two core elements of like, separating out, again, like what is somebody's exposure or acquisition risk? And I'll talk a little bit about the data that we have for Ontario and other places. What is somebody's onward transmission risk? And what are the conditions that put them at place for that? And then of course, there's a whole separate element of like the vast heterogeneity and severity that we know to be the case with COVID. So it's like separating out the infection related elements, which are acquisition and transmission, versus the sort of, you know, heterogeneity in clinical outcomes. But all of it, you know, it's intertwined, it's interrelated when we look at sort of single variables. But as we sort of think about what intervention strategies would look like, trying to, the more that we can separate out and create sort of granular understanding of these transmission dynamics, I think the more we get to thinking about what meaningful intervention strategies look like. So I'll just start with some data. This is a study that I was involved with in the US, and we did it with AMFAR, who is a group, the Foundation for AIDS Research. So, this is a group traditionally focused on HIV, but I think when we were talking with them in March, it started becoming abundantly clear by looking at data in New York City that, this was like disproportionately hitting certain areas of New York City very hard. And those are areas that were traditionally more racialized communities, higher population density. And so we took upon this to try to understand what were the dynamics happening at the county level across the United States. And I think what you could really see, and the way that this was split up, was looking at sort of disproportionately Black counties. And so this was separating out counties where more than 14% of the residents identified as Black or African American versus less so. And what you could immediately see were these trends. In blue are sort of all other counties, and in red were the disproportionately Black counties. And what you can see is there's sort of, and the darker the shading were, the higher the burdens. And even in sort of eyeballing, you could see that, especially in the South, which we understood to be the case in the early dynamics, when the South was less affected in general, so this is up until about May, you could see that there was really concentrations within particularly African-American or Black counties. And even in New York City, when you looked at the counties that have been most initially affected, just in the most severe of ways, these were counties that were more racialized in nature. So we wanted to try to understand that a little bit better. I'll say that initially we didn't see the same relationships with mortality. It was trending that way, but we couldn't really, it wasn't statistically significant. What I'll note is that over time, we saw that evolve that way as well, as I'll soon say. And while that was like a dichotomized outcome, actually what you would see is the more, the higher percentage of African-American communities within a county, so all the way up to 60, 75, 100%, or I should say not 100%, but moving up to sort of 80, 90% African-American, there was a linear relationship basically between increasing COVID risks. So this wasn't some sort of a dichotomized outcome. It really was a relationship that existed across the United States. But what's important is then to sort of understand, well, why is that? And I think initially people start talking about biological determinants, as we know people often do, and there was like the genome-wide association studies and others. But really, when you looked at this, you could see that, using like a PAF model, population attributable fraction, so trying to see what are the determinants that could like explain away the disparities, you could see that two things that were increasing the risk that could mostly explain away were the number of people living in a higher population density, so more than one person per room across all the models, the number of people that were uninsured, obviously in the US using a health insurance model, explained away the differences. And so these markers of structural racism, I'll note people who are unemployed were at lower risks, and we know that because a lot of this risk was occupational and these sort of high risk occupational exposures. And so actually folks who were unemployed actually were at lower risk across the board. But it was really when you started seeing these determinants of like how you hear the two things that came out were like people's living conditions, being able to explain away a significant portion of it, as well as people's insurance status or access to care. I'll note as well, when we updated these data about a month later, we saw that these relationships held true and were in fact getting stronger over time. So now, you not only saw the relationships between, sort of increasing percent African-American folks and increasing cases, you similarly saw that with mortality. And if anything, it actually looked like it was a stronger relationship predicting mortality than it was actually even initially predicting cases. And what you saw as well as sort of being really important predictors were this idea about people living who are people who were living in more dense environments. We looked at the similar dynamic with the same group for particularly Latinx communities, and I just want to show these data, and there's entire talks where we could talk about this, but I won't. Is to say, if you look at California as the cases were increasing, so on May 13th, May 15th, the states basically started reopening. You'd already seen this sort of like delineation in California between predominantly Latin communities or Latin counties, Latinx counties versus all other counties. But that since then, my screen is a little bit blocked, but you can just see that there's this intense increase in intense disparity that is happening there. And we have a paper about this as well, but you can see that, again, really in counties with particularly monolingual Spanish speakers, folks more likely to be working in farms or migrant labor. And so you could see again that obviously nothing biological, but these really are explained away by these sort of structural entities, structural racism that has changed the way how people live and how people work. But I think the disparities just were like, just such a glaring characteristic of this epidemic in settings across the board. And when they finally looked at this, I'll finish with US data here to say that you really see almost like this direct relationship between these racial disparities and COVID incidence and mortality. And I'll say that, AMFAR went on to show that this really seemed to be, dating back to like redlining back in the day, which some of you may be familiar with or not, but really zones where people had an easier time getting mortgages and loans in the 50s and the sort of COVID risks to date. And so in particularly really white counties, you see very little COVID, and in really more diverse counties, you see a lot of COVID. And again, nothing biological really related to structural determinants. Actually, the last thing I'll say is that even though these determinants are being seen now, in fact, it's not new. We're working on a systematic review of like respiratory illnesses in the United States. And this idea of disparities has been the case. It's almost like the defining characteristic of respiratory infections. And while I do traditionally work on HIV and disparities there too is a defining characteristic, it's super interesting to note that like the disparities, how quickly they form here. And I think just because the cycles of transmission are so much shorter than the cycles of transmission with HIV, that you see the evolution. So for H1N1, looking at hospitalization, you could see that Black non-Hispanic folks were really overrepresented. Similarly for Hispanic communities, and as well for Aboriginal American Indian communities. And so again, that the sort of determinants were really similar, and I think it sort of reinforces the message that like a lot of what has driven COVID disparities was in place long before COVID arrived. I think maybe that's clear at this point. Maybe it is, maybe it isn't. But it's that the sort of housing and working and access to care and all these determinants predate COVID arriving, and COVID has just sort of, worked and and grown within that framework. So, Eyal didn't say this, but I actually grew up in Sweden, so I'm like both Swedish and Canadian. So I've had a particular interest, I think, as many have, in Sweden throughout this pandemic. But I'll note this, that actually, while we think about Sweden as a place with like greater social programs, obviously similar to Canada, universal healthcare, more access to education, in fact, the inequities that are being observed, that were observed in the US also were observed in Sweden. So when you look in blue, you can, and red, you see sort of COVID-19 related mortality. So this is over 70-year-old folks in Stockholm that are outside of long-term care facilities. And you can just see this sort of direct relationship between square footage, or here square meters per person, and COVID risk, where the lowest, the least space that you have available in your home, the most COVID risk, COVID-related mortality. And I'll note, it's similar to other related mortality, that people who live in more dense environments have much higher mortality overall, but it's not like that they were protected from that in COVID, that increased. The other key determinant here was like the age structure of the household, and this idea of the multi-generational household where you're co-residing with somebody who's less than 66 was very COVID specific. So somebody of working age. And so, two folks who were living in the same household that were both of retirement age, there was virtually no increased risk, and they're basically the reference group. And really, it's the multi-generational households that just had this incredible COVID-related mortality. And then there was other dynamics. The last thing also is the population density, where you can see that the more dense the sort of community, which is also just a marker of kind of community level income and socioeconomic determinants within that, you see increasing COVID-related mortality within those communities. So now on to Ontario. So this is a work actually done with ICS, and so we're really excited to be presenting this. These are our preprints that should soon be out. So these are data mostly through this data for 14.7 million Ontarians across basically the first wave. And I just sort of want to highlight that it is absolutely the same case here. And so the two things I'll talk about is folks that generally achieve a lower educational attainment, but really the most powerful predictor across a number of different models and fully adjusted were the number of people that were living in the dwelling. And so again, to me, it starts feeling like this sort of global reality of the more dense your living environments, the more likely you were to be affected with COVID. And so, we can talk about sort of the details, but I think that really just jumped out at us as being something that's so powerfully true, and basically true in like a dose response relationship with, increasing density in the household and increasing COVID risks. I think the other thing that, and I think this is probably pretty clear by now, this is a Lorenz curve. So it's often used to look at disparities. And here what we're looking at is basically the community, like the total proportion of cases on the y-axis, and then the cumulative proportion of population. And we would expect that if COVID risks were evenly distributed across the GTA, we would just see a really continuous line, or I should say a straight line right up the middle of equality, where risks would be evenly distributed, and that would be that. And I think it's anything but, right? So I think it is now well understood that there are particular communities in Toronto that have been really burdened by COVID. And you could pick, for example, one point along this line to say somewhere about 50, and this is like spatial concentration, but somewhere about 50% of cases are in places that make up about 25% of the population. And you could sort of go along that it really is that these are, COVID has sort of, again, exacerbated these existing disparities. And it's something that kind of evolved over time. So, when you first started having some cases in March, these were more travel related cases, as you can see. And I think those, affected, actually, they were pretty proportionate. And it was really something that, as you looked over cumulatively through to July, this relationship is getting stronger. And I'll note, these are data at the neighborhood level. We've since, in working with ICS and others, are taking this to the DA level and doing some additional work and just showing how strong these relationships are, and the fact that they actually haven't decreased. Like, this idea that this is wealthier folks and it's now everybody. It actually is, at least for the data that we have available to us, is showing that these relationships of socioeconomic determinants remain really powerful in our province. So then that brings us to SARS, and I have the link here. I think we'll share these slides. I think it's fine too, but it's everything that I know, probably as a public health practitioner, really comes from this report. And if anybody's interested, I would advise, it's great reading for anybody who's interested. And particularly chapter 8, which is this idea about how we would do things better. So this is might be more of like a lecture than a talk, but I'll try to hopefully bring it back to reality, or to like what we're facing right now. So, I would just say, so like core public health principles that I've learned and that, we kind of tried to work by. One of them is equity. And it's exactly the case that, like, even in Canada, I know we like to pretend that like racism doesn't exist and other things don't exist, that we do better at, especially like compared to across the border. But of course we have inequities across our society. And I think what that means is that as public health, we should be aiming to do more for those who need more. I think social justice, the concept of social justice is that we should be really trying to achieve balance at an individual or network level of the intervention burden to an individual or to their family and the benefit to them. So it's not just that it's like personal cost and social good, but there should be some alignment between what somebody gets out of something and what we're asking them to do. And I think participation is a core element. I think probably many of us are clinicians. We engage our, whether it be our patient or our communities, in the decisions that are to affect them. So these are sort of the traditional principles of public health. And I think, you could think for yourself how we've used those lately. I think, characteristics of intervention strategies, they should be evidence-based. They should be human rights affirming. They should be efficient, which is to say that they should be proportional to the risk at hand. Obviously, they should be effective in real-world settings. They should be acceptable to the people who we're asking them to engage in. They should be affordable to the individuals. So this isn't affordable as in like cost-effective. This is if we're asking somebody to do something like isolate at home, we should make sure that that's affordable to them. It should be practical and accessible. It should be delivered with empathy, and it should be contextually appropriate. So these are, when we think about intervention, these are like the sort of characteristics that we should be, and I hesitate to where you should, but I would just say that we traditionally would use in thinking about like what is a meaningful intervention or not. The precautionary principle is a principle that has been used a lot over the last 8 months. It feels it's said all the time. So I just thought it would be like something just to quickly run through, and if it's obvious to everybody, I apologize. But the precautionary principle is commonly used in public health when we can't do an effective risk assessment. So if we don't know like the severity or the hazard of a particular event or agent or intervention, then we just say, listen, we don't know, and we're going to assume the worst, and that's what we're going to do. But I think it's really important about like how we use the precautionary principle, because often it seems to be used as like assessing the potential benefits of an intervention in isolation. But that's not traditionally how it was used, right? So the idea is that a precautionary principle would assume and try to like hypothesize about what are the potential benefits and the potential harms, both along a continuum of probability and also ideally putting some time scale into it. So I don't think we can just slap the precautionary principle on any intervention and say, well, if we don't do this, society will fail. I think there still needs to be the idea of like some empiricism as much as possible to then decide like what are potential benefits and the harms. And there's some interventions that feel like they have less harms. There's some interventions that, we could assume have great harms. And I think, the idea of like just, using precautionary principle to sort of to take away from the need to engage in that conversation feels disingenuous to me. And I also would then argue that I think this idea of like proportionality should still guide the response, that we use some element of proportionality in how we decide on like the sort of scale or the breadth of intervention strategies across like sort of geography or across the population. So, when we think of intervention strategies in public health, normally we would intervene at multiple levels. And so, we intervene with like individual risks or individual needs, network risks and network level needs. And I'll bring us back to a real example and soon. And then structural elements. And so, when we think about this, I'll also say that an intervention strategy in public health, at least the way that I'd learned in, and speaking to many of my colleagues who did the same public health training in Canada that I did, was like a positive intervention, like the delivery of an intervention, not the default to a restriction. And that I think it just has to be said feels kind of unprecedented in 2020. Often we use like the E's to think about intervention strategies. So the idea is that normally you wouldn't just like do a single intervention, but you would think about packages of interventions that are aiming to act at multiple levels and are, again, sort of like aiming to be as empiric as possible. So economic interventions, whether that be, like the CERB, or if it's something like asking people to isolate, again, ensuring that they have the means, they're not like facing eviction because, they have no paid leave, for example. Environmental controls, so we've heard a lot about ventilation and other opportunities that exist to provide environmental controls. Engineering interventions, education and empowerment as being critical. And I would say after all of that is done, then you might think about enforcement, but it really, I think enforcement is like a failure of public health. And that when we get to that, when we're at the stage of enforcement, we've actually failed, and then we're asking, police to jump in or something. And that at that point, again, I just would highlight that I think that's a failure of public health. Okay, so kind of bring us back a little bit to, Ontario or Toronto specific data. So, there is a real relationship that exists between occupational and community level risks. And so these are data that are looking at long-term care facility workers and sort of overall proportion of cases. And what it basically says, sorry, the Zoom thing is blocking half my screen, so I'm gonna move this. So what it basically says is that, if we know where the long-term care facility staff live, I should say, and obviously we know that they're long-term care facility staff. If it was irrelevant where they lived, in the communities in which they lived, we would again assume equality. That sort of line right up the middle, the orange line up the middle, which is to say that cases in communities would be independent of long-term care staff facility living there. But that's not the case, right? It is the case that there is a relationship, and that's why you see that sort of the Lorenz curve pulling it up, because generally speaking, the more long-term care staff facility that live in a particular area, and these are non-shelter cases and non-long-term care cases, actually results in higher risks to those communities. And that only applies for long-term care facility staff. So it doesn't apply for physicians and nurses. We see more kind of equality around that. And so the sort of isolation of the network that exists from somebody's occupational acquisition and the communities in which they live. So, what do we know? Well, we know that there's geographic heterogeneity. We know that about almost 50% of long-term care facility staff live in the top quarter worst hit areas by geography. We know that, the almost 50% again of long-term care staff cases were in the most sort of the lower income parts of town, the most materially deprived areas. And we also know that there's elements of structural inequities and structural racism, because also about 40% of folks in long-term care staff, from long-term care staff, lived in the top 25% sort of most diverse parts of Toronto. And the GTA. And so again, that we're seeing these real concentrations of risk that exist in our city. This isn't somewhere far away. This is home. And just a tremendous amount of heterogeneity. And I think that's very, sort of reflective of what we've known. We just released this paper. This is looking at sort of percent cases over time. In blue are the sort of community cases. The rest we call the rest of the population. In purple, you can see in the shelter settings, which is where I provide care. And then in the red or the orange, you can see, for long-term care facility cases. And you can see if we actually had it on a single scale, it wouldn't work, because it goes so far off that it's so concentrated in these communities and I should say these facilities, like geographically in these sites, that you can't even look at it in a meaningful way on the same scale. So that sort of then brings us to that's like our framing is, that this is an infection that not only across the United States, not only across Sweden or in Stockholm or in Ontario or in the GTA, is so heterogeneously, the communities are so heterogeneously burdened that it brings us to sort of this idea of restrictions-based responses. And I'll say, in speaking to many of my colleagues and having done the Royal College exam in public health in Canada and passed it, I don't remember this as like a go-to response. So that feels like that's not a evidence-based thing. That's just my own reality. And we'd have to do some sort of systematic review of understanding how these have been used in the past. But, in thinking about them a little bit more empirically, the idea of a restrictions-based response would suggest that risk is evenly distributed. It would suggest the inability to characterize disparities and thus unmet needs. And it really does represent our responses across the province for now, that we're closing indoor dining and gyms and strip clubs as I'm sure many of you heard in the last hour, we're shutting down Halloween in Toronto. And so I think there's a real question about, like, you know, how does that kind of match up with some of these core traditional principles? I took these photos. A friend of mine sent them from San Francisco. So this is how they've been addressing the interventions in San Francisco, like taking down basketball courts and taking down swings, etc. The data, I'll just to like kind of jump in for one time. This, you know, I looked at the science table report. I just, with all due respect to the folks on there, I know it's incredibly difficult, and nobody wants to be the Monday morning quarterback. But I wanted to try to understand the indoor dining question. And so and the link is there for the most recent science table report, they sort of highlight the risk. At least this was the only thing I could find that related to indoor dining. So there may be other things. But they used a study to show that from the United States, that basically in univariate analyses, so like unadjusted analyses, the associations with like COVID cases were ethnicity, education, underlying medical conditions, and going to locations that offer on-site dining. I'll note, they don't talk about if people are working there, are doing dishes there, or delivering food from there, just that they had been at those places. And I think ideally from that first part of this talk, when we talked about like how to understand disparities by ethnicity and the importance of structural elements within that, one would see that like maybe it wasn't going to restaurants that was potentiating risks in some of those communities. And so I just wanted to highlight that like an empiricism might be in short supply at this point. So I'll just say, so just to sort of say a few last thoughts. So one, like as of October 19th, we are back. You know, we went from 58 long-term care facilities in outbreak about 8 days ago now to 71 long-term care facilities. You know, and I would have argued, ideally from the data we've talked about today, about the intersection of where somebody works in long-term care facilities, where somebody lives in more economically marginalized parts of the city. One would have thought that an empiric response would be different. Would it be to like think about like what are those unmet needs? It turns out, and many of you may know this already, that like many folks can't get paid leave. WSIB even is incredibly complicated, having gotten into the weeds a little bit for shelter staff about whether they can or can't get you know, paid leave when they're under quarantine or isolation. So I think it really begs the question, as we're seeing more of these cases, asking the questions empirically as to why, and wondering if people would still consider working with mild symptoms, or if they maybe had a contact because they're just concerned about being able to meet their basic needs of themselves and their families. So I think, you know, this idea about paid leave, housing support, as we've seen, like this, it might be the only universal thing that I've been able to see in every place I've looked where they've asked the question, where people are living in these sort of broader households, multi-generational households. And so thinking about whether we can provide those services. I'll note, we set up the first recovery site for homeless folks, but that's only really for homeless folks. And it's not for unstably housed, et cetera. As of, you know, September, we finally set one up, but I think, you know, the idea of scaling those and making sure that they are sort of something that people are aware of as part of the response. And then I would still say that I think overcoming any barriers to testing in healthcare, we always have to ask ourselves, like, how would a shift worker who's, you know, doesn't get paid time off be able to stand in line for 3 or 4 hours, or may not, you know, English may not be their first language. In fact, it often is not, you know, be able to sort of navigate these incredibly complex booking sites, you know, to get tested. And might there be other barriers like anticipations of being fired if they were to test positive? So I think thinking about that as we're now like going back into this dynamic, because we've estimated about 25,000 long-term care facility residents still have not had COVID, still are, you know, are at risk. And I you know, I think it's that question of like, what have we done for that? So I'll just finish with a few things. One is, you know, early modeling for COVID, that first generation of models really assumed homogeneity. Like, you know, they would assign a reproductive rate to different age groups, and then they would use this sort of age stratified risk. And you know, I think we really have to ask ourselves, like, did it play out that way? Do we just plausibly expect respiratory viruses to play out that way? I think that, like, at least to date, we've not seen that play out that way almost anywhere, that we've seen this sort of marked heterogeneity in terms of like acquisition, transmission, and also severity. And I think, you know, there's an opportunity to sort of think about how we leverage data on heterogeneity to guide these sort of responses. And you know, that is to say, it actually would take more work to do this than universal strategies, and it's not cheap. But I do think it's a path forward that really affirms rights, and you know, I think, and aligns with our aspirations that we often talk about for equity within our health systems. So I really want to acknowledge Sharmista Mishra. She's the PI on a lot of the work I talked about, infectious disease doc and modeler at Li Ka-shing and St. Mike's. Jeff Kwong at ICS, I think many of you will know him, and a whole group of folks actually that are really fundamental to this work. There was funding now from CHR with multi-provincial work, and I'll just note, these are very consistent trends across Quebec, British Columbia, and Ontario, and we'll see how it evolves as we get more cases in some of the other provinces. Similarly in Alberta, I'll note also, and so just to thank a lot of folks. Okay, thanks very much.
Thanks, Steph. I think we got time for some discussion and questions, and I welcome people to either use the raise your hand function or chat and turn your camera on. If you have any questions or comments you want to make. Maybe I'll start while people are thinking of comments or questions. So, Steph, you know, you made a pretty compelling case for why we need to leverage data on heterogeneity to inform pandemic responses. But other than saying it's complicated, I'm still struggling to understand why it hasn't been actioned, not just here, but in many, many other places around the world. So, you know, the decision makers in public health tables have the same training as you. So can you comment a little bit about why, despite this, you know, overwhelming knowledge base around this heterogeneity, we still struggle to implement policies to support to support strategies that will actually address these issues?
Yeah, I mean, I think one thing to sort of understand at this point is early on in this response, early March, April, there was a relationship between the more decisive political leaders were seen to be, and the more we sort of heralded that success. So I think that one thing to ask ourselves is like, and I do think it is a very real question of like, what's political and what's public health. And it's hard for me to separate out those things. I think it is hard to delineate, you know, what of this is really sort of like core public health principles and what's political. I do think from a political perspective, I do think that there's a little bit of an out that when things are going bad, like enacting restrictions isn't hard. Like it's not fun. I'm sure that they don't like doing it either, but it's not like it's hard work. Because you just have to get political agreement and then you just kind of do it. I do think intervening is hard work. I think the idea of like an intervention-based approach is hard work. I'll note, you know, it would require, you know, taking on really complicated elements around like how we do paid leave in this province, how WSIB works in terms of approving people to giving them some money while they need to isolate. And there's like, those things are complex. But one would think that they would cost pennies on the dollar to what's going on right now. And so I think that it's a little bit unprecedented in terms of like how we've reacted. But I think one thing we have to keep in mind, and I'll just say this, is like, it's not our last pandemic. You know what I mean? Like, you know, this is like, we could easily have another pandemic like this in a couple of years. And I think we have to think about how we look at our pandemic preparedness documents that exist and are really great documents, but like ask why they, you know, across the board weren't used in the way that we would have expected them to be used. So it might have been that they weren't easy to use, they weren't easy to communicate, they weren't, you know, and I think so it might be the sort of like the content of those pandemic preparedness documents, and it might also be like how to implement them, how to communicate them in the social media age. The last thing I'll just say is that I do think that like the approach by traditional public health practitioners may be a little bit different than like clinicians, where like, I think for clinicians, like aggressive therapy, aggressive decision-making, especially like our intensivists and our emerge docs, like those things, that's championed, right? We want folks to be decisive in the time of emergencies. I think for public health, it doesn't translate that well. I think that often we talk about like, well, the house is on fire, we have to make decisions quickly. I would still argue there's time to do an hour meeting. Like, it's not like the house is actually on fire. Like, we can sit and have a conversation and think about like a dashboard-based approach to evaluation, et cetera. So I'm not trying to provide judgment, again, as like one individual coming down on other individuals, but I do think I'm just sort of presenting like traditional public health principles, and then I think people can make of it as they wish.
There's some excellent questions in the chat box. I can't read them, but
I'll find them.
I prefer to have a conversation with the people who are actually asking them. So the first one is on data in Sweden showing that having a child in the house reduced the risk compared to having just a working age person. Can you explain that?
So, I mean, I think one thing about Sweden, I'll say this, hopefully I won't get in trouble for saying this. So my mom's in Sweden. I've always said that like, there's nowhere else I would have rather her be during this time. So just my thing about Sweden. But that aside, I think that a big part of the work in Sweden, that now has been updated into that Nature paper that I linked to. So I think when the slides are made available, or we can share those. I think it said a few things that like, so schools in Sweden under 16 never closed. So just as an important note, for age 16 and under. And so, that there was a sort of this initial study of like trying to understand what were the relationships that existed between the fact of like having a kid still in school and potentially living with over 70. And I think as was said there wasn't that relationship. They didn't see increased mortality amongst those. It looked very much like baseline. Where they did see was having somebody in the household who was of working age. And I think often the idea being, I think maybe similar there to what we saw in Ontario, is that people's acquisition risks are outside of the home, and then their transmission risks might be inside the home to those people over 70. So, that if you sort of think about it separately, that maybe the kids under 16, 15, just don't, obviously their acquisition risk is probably similar, but it might be that their transmission risk is not, because at least those data didn't show that there was increased risk. A more updated study of that has similarly shown that like, it might be that parents of 14-year-olds were at increased risk, but it really, across the board, parents really weren't at increased risk from kids that were in school versus kids that were not in school. So I think that's an important thing. So individual risk factors such as smoking, obesity, or associated with COVID-19 may or may not be entirely. So I think this question about smoking and obesity are really important. And I think one is, and what we'll see is that like, there's a bias that exists in COVID-19 that might be unique to COVID-19, where we've used case rates as our ways of inferring causality in real time. And obviously those are biased based on who's being tested. It may be that smoking is subject to collider bias, which is that smokers were more likely to be referred for testing. And in some of these models with ICS and others, like smoking may look protective when you start adjusting for differential testing rates versus, and so it's not that actually like smoking is protective, obviously, but it is to say that it may be that there's this collider bias that's really powerful that we need to sort of think about when we're trying to infer causality. I think obesity is separate. Obesity has shown to be, even independent of case, has been a marker of increased mortality, not necessarily acquisition, but definitely morbidity once somebody's infected. And I think, what one could also think about, like, what is the relationship between obesity, at least in the United States, and I'd have to look more at the Canadian data, but the relationship between obesity, health literacy, income. We know that there are things like eating healthier is more expensive. We know that there's a relationship between health literacy and exercise and gym access and public spaces access. So at least in the United States, obesity is far more related to structural determinants. I don't know as well in the Canadian data, but my guess would be that there's probably similar sorts of trends of relationships that exist there, where generally higher income communities might be less likely to be obese. So I would just say that I think all of it is to say that, like, COVID presents, like, to me, if we could do anything with COVID, it is also to look at like these underlying structural inequities. So it is absolutely the case of like empowering, I think maybe the answer is integrated into the question, but it should absolutely be of like, what are the underlying determinants that have put people at risk, whether those be housing, working, or individual health literacy, health promotion? This country, we focused a lot on health promotion. We talk a lot about it. I've not really seen the core principles of health promotion be like, really a core part of this response. So I think that the comment there reinforces that we should be thinking about like how we do particularly, empowerment messages or support as part of the response.
You're reading
to impose. Yeah. So I mean, so I'm reading a question, and I think this is like so. I'll say it's like, maybe I'll say, I think we're a private group. I don't know if I'm not being, maybe I'm being recorded. That's okay. I mean, I would say, the idea of targeted lockdowns to me is like, I can't understand it at all. That we take pre-existing conditions, whether they be housing and working, et cetera, and then we do targeted restrictions in just those centers, feels like it's punishing people for the very conditions that like many of us maybe on this call benefit from, like that these inequities exist and we might find ourselves on a certain side of it. So I do worry really in a very real way about, so for example, New York City, some of you may have seen this. There was like, de Blasio wanted to shut down 9 parts. In fact, now they have closed down 9 parts of the city. And, they've like said, well, it's the Hasids, it's this, it's that. But like, actually, these are parts of town that are like way more population dense, are far more racialized communities, are lower income. So it's like, if you close those down, it just asks the question, like, if people have occupational risk, do you let them out? Do they still get to deliver food to wealthier parts of town? Do they still get to, work in Amazon fulfillment centers or meatpacking plants, et cetera, where their actual risks are? So I think it's the question, I think, by Melissa is a really important one of like, an equity lens absolutely would say that we should be providing resources where we see these disproportionate risks and not defaulting to restriction, and especially targeted restrictions when those are, particularly unmet needs. So I just want to sort of make that point. I think, so I'm just reading.
I'll read them out for you. So Catherine Berger just made a point in addition to the comment you made about obesity and smoking, and
right.
that obesity and income have as strong a relationship in Canada as elsewhere in adults and children. Then there's a question from Ann Fuller where she asks about disparities, especially the geographic ones, that they can really be reproduced for so many other acute and chronic illnesses.
That's it.
And attributed to a variety of driving mechanisms. It's interesting because you spoke mainly around communicable diseases, but you could have easily given us a talk around non-communicable diseases.
Totally.
So the question, the question is, how strong is the evidence that specific mechanisms you described to feel confident that directed intervention would reduce these inequities? I can think of other outcomes where the worry has been raised that there are so many factors leading to inequities that where do you begin?
So I think that's really important, and I agree. I think I use an equity lens to all parts of life, and I think that it's sort of like the be all end all of what we do in public health. But I think that's also kind of part of the point, is that because these determinants are so powerful and so prevalent and so determinative in terms of health outcomes, the idea of like ignoring them with sort of like targeted restrictions doesn't address the underlying issue. And I think in public health, I think it's easier when we are empiric in terms of how we address. So what I would say is this, is that, I think that there are ways to like think about like the causal pathway of risk, that the more upstream issues are not things you're going to be able to fix. Like you can't fix structural racism during an emergency. But I think that one can look at the more downstream determinants and try to think about like strategies to address those in as proximal to the actual acquisition or transmission event as possible. So I agree with that. I don't think this is specific to COVID. And I think it only reinforces the point of like looking in the mirror before we shame, blame, and criminalize folks. in terms of our systems. But I also then would say that the intervention strategies should be responsive. And I think we can really look at those proximal outcomes. So in HIV, that might be, you know, targeted implementation support in you know, particularly like in gay clubs or gay communities, et cetera, or like enriching or enlightening strategies or empowerment strategies, et cetera, where we work with communities. And so if it had been me, like, you know, I think we would be talking to community groups that support the communities that have been disproportionately affected here. We talk with them and think about, like, what does a meaningful intervention strategy look like? How can we deliver it? How can we message it? And then, and where do we maximize public health outcomes there? So I think that I think that's kind of at the heart of all this, is that, you know, this epidemic has actually just like leveraged existing inequities, but I do think there are opportunities for intervention. I don't think that they're so big. The underlying inequities may be, but the actual proximal determinants of infection feel more tangible if we address those with resources before we do with restrictions. And so I think, yeah, so there was a comment here about, I really do think that, like, so this point I think is being made about like engagement with high-risk communities. I think we'd be hard pressed to find a community that's been disproportionately affected that wouldn't have community groups or community leadership, key opinion leaders, like the traditional stuff we do in intervention development to do engagement, to try to understand optimal messaging, optimal delivery, et cetera. So I do think that there is a way of like ensuring that this isn't, you know, people saying, well, you know, all of us need to sacrifice. But I'm like, yeah, but for some of us, sacrificing is like not traveling to Baltimore. And some of us is sacrificing is like, I'm not sure I'm going to eat tonight, or I'm like at risk of eviction, or I've lost my job. So I think that there is kind of aligning, I think as a starting step, I would say, is aligning like social costs with personal costs, or social good with personal costs. So right now we have an intervention strategy that asks people to take on personal costs as a social good. And what I mean by that is that, like, you know, if you have mild symptoms, you're fine to go work. Like you're okay to go work, but we're asking you not to. But we're not providing you resources to do that. And I think that like disconnect is one that feels particularly problematic to me. So in the very first step, I would talk about like this idea of like aligning personal costs and like kind of the social good, and ensuring that folks are not, that there's not the sort of significant disconnect that exists right now. So I just would say that I think it's, I think that's fundamental and is a starting point, at least for the interventions. And by the way, like the cost of which would feel like pennies compared to what we're doing now. I mean, you know, I can't imagine the cost of what we've done to our societies, but it feels like addressing some of these things would be far less expensive. And I would have thought the appetite was there for many of us. And so thanks very much for the comment. I agree. I really think structural determinants of health are fundamental here. So, and then, I mean, maybe I'll just finish by saying that, like, I think there's been, I think this idea of like proportionality in responses, Eyal and Aster and when we were talking about sort of this intervention, I would just say that like the idea of like empiricism at their core should be driving our responses. The idea of thinking about potential benefits and harms of interventions and equity, doing those things, I think brings us to just a more meaningful and specific response that actually addresses needs with resources rather than restrictions. So I don't think it has to be like my opinion. I think these are core Canadian values, at least that we espouse as Canadian values, but that I've not really seen represented as much as I would have thought during this time.
Steph, before we conclude, I'm going to ask you a thought-provoking question that has emerged in the media in the last little while. If there is a successful vaccination target in the near future, should we roll it out first to those communities that you have spent the time talking about today? So there's been a discussion in the US where Black Americans should be the first to receive the vaccine, to give an example. And if yes, do you actually think that's a realistic thing given all the structural inequities that continue to exist in our society?
Yeah, I think it's such an important point. So like vaccination in the past has you know, reinforced disparities. When we looked at like after H1N1 in Australia and other places, just based on the underlying determinants, you know, it increased risks and increased disparities. So, I mean, I think, you know, there's higher levels of medical mistrust. There's higher concerns. I think that we would have to overcome. So what I would be doing is absolutely like targeting vaccination strategies in ways that make most sense. So first of all, we can talk and get into the weeds about it, but I do think looking at individual network risks as ways of thinking about how to vaccinate, but also thinking about how to sort of roll out interventions in general. But the complexity there is that I worry that public health has fractured its relationship with the non-Twitter communities, like communities not on Twitter, in ways that I think is going to take a really long time to heal. I think the idea of being able to engage those communities has been fractured in ways that will not be easy to overcome, and the idea of trust. So I think it's going to have to start with working with community groups that represent those communities, trying to build leadership, whether it be through religious leaders and community leaders and others. But I think it's going to be I think we've made it harder for ourselves to do traditional public health programming based on my concerns around fracturing the core element that public health needs to have with its communities, which is trust. So that's just a challenge that lies ahead.
So on that note, on behalf of Child Health Evaluative Sciences at SickKids and the Leong Center, I want to thank you for sharing your wisdom and insights today with us. And thanks everyone for joining. And Steph, hopefully we'll have you back.
Yeah, no, I'd love to.
All right, take care.
Okay, thanks very much. Thanks.